radiation oncologists don't feel comfortable having imaging of a patient come from a different facility. They like to repeat some of those studies. And so all of that had to be done so that a decision is made in terms of the patient disposition and how are you going to be treating that patient before you start the treatment planning process. So that was a step that was introduced in the clinical workflow. So these are the sort of things you have to think about, how you're going to be dealing with the patient's comfort or convenience to make sure that they're not making too many extra trips for radiation treatments. So the need for optimized workflow in proton therapy comes from that the dose calculation delivery of proton therapy is highly sensitive to various sources of uncertainties, and some of them were discussed at the Monday morning SAM panel discussion that we had. There's CT to Hounsfield stopping power conversion. There's an increased RBD at distal fall off. So these have ramifications in terms of what type of imaging we're going to be doing, what type of assessment we're going to be doing, what type of a plan evaluation we're going to be doing. There's some dose calculation uncertainties mostly occurring because the dose that you compute on a static image, and when you apply it to a patient, because of all of the intrafraction motion as well as the physiological changes, there is going to be dose uncertainty in terms of what is the dose delivered to the patient. So those are the sort of things. You have to actually look at those things so that you can deliver a prescribed dose to the patient. And then there are physiological changes, high Z implant artifacts, organ motion, and tumor regression and progression. So here is a workflow that we look at as a patient selection for proton therapy is done